This will be our proposed anesthetic plan for this 50 years old lady with A-stage renal failure come for open cholecystectomy. Our decision is to do a general anesthesia for her because the incision site is above the umbilical cord. Therefore, spinal anesthesia might not be effective or adequate for her. In addition, in view of her long operation hour, this will be safer for us to go for GA with positive pressure ventilation. So as usual, we would like to prepare OT by checking the GL machine, the airway, the drugs, fluid, and other equipment. And also to make sure that the OT table is well prepared with OT humidity, temperature is optimized for patient safety. So when the patient reach OT, we have to reconfirm the patient identity, check the consent form, do a PE to make sure there's no fluid overloads, and also reconfirm the last meal eaten, and also ensure that there is adequate NPO time. And in this particular patient, I would like to identify the vascular access and avoid spare arm or any BCF or pump catheter that need to be cautious on. And also to consider invasive BP monitoring by set an arterial line before the induction. So for induction of anesthesia, we would like to maintain the pre-oxygenation end tidal above 85% with IV induction and maintenance with inhalation. So in this particular patient with A-stage renal failure, our concern for her drugs of choice would be depend on the creatinine clearance, hyperkalemia, pre-existing metabolic acidosis, and also hypoalbuminemia. Therefore, all drugs have to be renal adjusted based on the creatinine clearance. In addition, all the antibiotic given have to check the last dose, frequency, and the dosage to avoid overdose during the surgery. So for resuscitation drugs, we would like to prepare ephedrines, atropines, and phenylephrines. For drugs induction, we are going to give 3 pellets of anesthetic drugs. First, we will give IV fentanyl with 1 to 2 microgram per kg, followed by IV propofol 2 to 3 milligram per kg. Well, for muscle relaxant, our choice would be either IV atracurium or IV susamectonium for rapid sequence induction if the abdomen is distended or the NPO time is not enough to prevent the aspiration. However, this IV susamectonium have to be used with cautious because it can cause transient hyperkalemia in this patient. Therefore, we can only use if this patient did not have hyperkalemia during the time of induction. So after we give muscle relaxant, it's easier for us to go for intubation, and after intubation we connect the ECT to a GA machine. And now come a question, why do we choose for other induction agent? So here is a list of example of drug which can actually worsen the renal function. So for example, entomidat can enhance hypoalbuminemia, while ketamine and benzodiazepine can cause active metabolite accumulate in the renal tubules, while barbiturate can result in decrease of the protein binding, which can worsen the acidosis. Well, for maintenance and monitoring, we would like to use sevoflurane for gas maintenance and keep the MAC around 1.0, and it have to be depend on the depth of the anesthesia also. Ventilation need to be more cautious on in this particular patient. This is because inadequate ventilation can cause progressive hypercapnia under anesthesia, which can further lead to respiratory acidosis and causing exacerbate in the pre-existing acidemia patient that result in severe circulatory depression. And it can also increase the potassium into a certain dangerous level, which could lead to arrhythmia. Therefore, hemodynamic status and monitoring with ECG is very important in this part. Further on, so let's say if the patient is anuric, we might need to consider colloid for volume expansion and watch out for fluid overload and any electrolyte imbalance, especially in this patient who have renal failure and also abdominal GI loss. We also need to maintain the humidity in the OT because abdominal surgery can increase the insensible loss in this patient. Well, for intraoperation analgesia, we would like to give fentanyl, which is safer for this patient who have renal failure. And we might need to avoid NSAID and also this morphine, which can worsen in this kidney failure patient. Okay, that's all for my part.